Good morning, everybody. Welcome to another edition of the AFR EMS case studies. My name is Chris Ortiz. I'm the EMS division chief for Albuquerque Fire, and today joined by our medical director, Dr. Kim Pruitt.
Hi.
All right, and also Lieutenant Greg Ochoa.
How's it going, Chief?
Welcome, brother. Thanks for joining us today.
Good.
So we got a cool case. Today we're going to discuss cocaine-induced SVT. And this stemmed from a call that you on Rescue 8 responded to as a 23 Charlie for a 47-year-old male.
Right.
Remember that call pretty well, right?
I do, actually.
All right, so you guys are en route to that call. What are your thoughts when you're starting to go en route?
So I had a good idea based on dispatch reports. They had some good information. It said possibly drug-induced, but they didn't have a specific drug on there. So I kind of reviewed that with my partner. My partner's been my partner for a long time, so we were raring to go.
Yeah, I got the opportunity to visit up there a while back, and
Right.
It's a fantastic team. You guys,
Thank you.
good experience and a good crew. All right, so you guys are code 3. You get there, single-family residence. It sounds like you found a gentleman who was laying in bed. Talk us through what you saw and what your interaction was with him.
So speaking of great teams, AAS was on scene first, and they had a student. So students have this wonderful effect of getting you or keeping you on your toes because they're up to date on all the newest techniques, and this is one of those calls where when you find it is SVT, an extremely high heart rate, they know it, and that's the one they look for because they get to push a medication you don't often get to push. So they were kind of already set up. They had put the monitor on it, and it was SVT on the monitor. It was a narrow complex tachycardia that was regular, and the student there was excited. She has some experience in the ambulance company, so she was sort of excited that she was going to be leading this call. So they were setting up, and we just sort of jumped in there. I got a brief history and crack cocaine, which, I haven't seen much in my career.
Right.
Very few and far between, but crack cocaine was mentioned earlier that day.
Yeah, students are great because they help refresh us, and their eyes are seeing it from a different perspective a lot of times, so that's good. So even before we get to the cardiac monitor and what you saw, I think one of the biggest factors for us is how the patient presents, what they look like, what they feel like, getting hands-on. So describe to us, even before you got to the monitor, before they got to the monitor, how did they present to you? What did they look like?
So this gentleman on this particular case looked sick. He was pale. He had a little bit of clammy skin, and he had that kind of look on his face, that grimace that he didn't feel well.
Right.
It was that malaise, and you could easily see this person was sick.
And as far as his history, and I love the sick versus not sick, 'cause that's our bread and butter, is to identify who needs help immediately, and who can we think through these things a little bit more. So it's great. So we talked about the recent history of crack cocaine. Did he have any other past medical history that was pertinent that he brought up?
So yes, which actually made the dynamic of this entire call. As I said, calls are dynamic, and this one sort of was confusing because he had a history of SVT, which had been resolved by adenosine usage in the past. So that sort of dictated a lot of our treatment, and we were all kind of in almost immediate agreement that that's kind of where we needed to go. So that threw us off, and as far as the stimulant use, it could have been either one, and we did consider it. In fact, we had that conversation kind of, I don't like to speak about people as if they're not there, but over him about our treatment options for him, and we kind of agreed that we'd go down the SVT route, considering his history and that he'd been converted prior.
And that's a great point you bring up, and Doc, I'll kick it over to you to talk through that real quick. So this was a unique case into where the patient had a history of SVT, and that's what we saw on the monitor, but there was also attributed to drug use. Now, we also have situations where there's no history of SVT, young, healthy hearts, 20-something years old, and then they have admitted to drug use. How do you want us to handle those situations differently?
So I think what you guys did is excellent. You saw SVT on the monitor. You saw that he was sick and he needed some immediate interventions to help stabilize him, and you knew the treatment. So if they're stable enough or cooperative enough to try the vagal maneuvers, that's always nice. Sometimes it works, sometimes it doesn't. So you have your adenosine ready to go, 6 and then 12 as close as you can. Right. When you have that like very fast, very narrow, very regular tachycardia, that's like you said, a bread and butter call that the students love, and it's satisfying because a lot of times it works. I think in this particular case, did you tried adenosine a couple times here, right?
We did. So we did the vagal maneuvers. We also did a fluid challenge on this patient, and that didn't work either. But
excellent, though. I'm glad to see you do that. So then when you throw, to your question, Chief, when you throw another drug into the mix, we already know with this particular patient, his heart may have had a reentry circuit or already been prone to SVT as it is, and sometimes even caffeine or no sleep can kick that off in people. In this case, it was probably the cocaine that sent his heart into that reentry circuit that needed to be stopped. And so adenosine works. But if it doesn't, and you know that it's cocaine or another stimulant, or you suspect another stimulant when your adenosine's not working, it's very appropriate to think about benzos at this point. And then more fluid as well, because that fast heart rate makes you tired and dehydrated.
Right.
And you want to fill the tank.
Yep. So we tried the vagal maneuvers; those were unsuccessful. We tried a fluid challenge, and those were unsuccessful. Any changes with the adenosine after you pushed the 2 doses?
So it did, which was weird because this particular patient had a very predictable, regular rhythm with that narrow, complex tachycardia. It was just marching out perfect, and after the adenosine, it became irregular. So it was irregular, and became this AFib with RVR, this rapid response. So after we did all our interventions on scene, again, the student sort of helping us, we asked, what would you like to do? And transport. And I like to say to my students, transport is treatment. Mm-hmm. And that was the treatment that she elected. They were going to do other interventions en route, but the transport to definitive care was the ultimate decision. I think that was a great decision on her part.
Right.
So we weren't privy to that. Kind of a letdown. It's what's best for the patient, but we want to be in there. We want to participate.
Yeah.
But as soon as they left the scene, we kind of reviewed over. I spoke to you about the benzo. It's a great idea, and something that I hadn't quite considered, but
it's so rare. Like you mentioned, like you rarely see cocaine here in Albuquerque. I feel like I was telling Chief before we started, I feel like we're seeing it more and more. So this is excellent timing for this case.
There's like a resurgence. Yeah, I totally hear that, actually.
So our treatment is always going to be based on presentation, mostly with these reentry and these abnormal rhythms, is the hemodynamic stability of the patient. Right. So it sounds like with this patient, any chest pain? Never complained of chest pain?
He did complain of chest pain, but it was, which again, part of the dynamic of a call, he described it as a fluttering or a pounding in his chest, and we asked him to quantify, like we do the PQRST. While he was willing for most of the call to converse with us, he couldn't quite give us a number. He just would tell us, no, it's bad, it's terrible, help me, sort of thing, just sort of demanding us. So we did our best, but chest pain was mentioned, and we did discuss going through some more protocols, aspirin usage, especially considering that after the adenosine was administered, it became irregular, and we didn't want him to throw a clot.
Right.
And it was mentioned about
his
the
level.
chest pain.
That's great. That's great. Great thought process. And his level of response stayed up. He was never hypotensive. Sounds like, on the contrary, it was 170 over 98 for the initial, so never had to go down that step. But if he was to have that sudden change in his stability, what was your next plan, or what were you thinking through after that?
So this was actually my partner and I discussed it afterwards. We were thinking maybe going down the benzo route, but not for the stimulant, but to start going down the unstable portion of this protocol, possibly synchronized cardioverting this patient, and to kind of sedate him. I know we have fentanyl available to us, but I think in this case we were kind of agreed that this would be the time for the benzo to help us sedate this patient, then cardiovert.
Absolutely, and you may even find if you gave that benzo, anticipating if he was to get unstable, that you may fix the rhythm.
Right.
You would improve his, at this point he was hypertensive and tachycardic, and those are signs of a stimulant too. And the benzo may just take that edge off and bring him back to a normal rate. Right. The other thing is the fluid may help as well. Sometimes I always find it interesting how well fluid can help an AFib with RVR sometimes.
Yeah, you guys did a fantastic job, you, the Albuquerque ambulance crew, the rest of the station, to methodically think through every step of this patient's treatment. So I think ultimately you guys made all of the right decisions, got this patient to definitive care, and then hopefully doesn't have any more of those reentry issues. But the fact that he had the reentry issues plus the use of cocaine made it a super interesting call, and I think you guys knocked it out of the park.
Thank you.
That's a great job.
Excellent job with this one.
Awesome. Well, thank you, LT. I appreciate you joining us today. So that's it for this edition of AFR EMS Case Studies. If you have some interesting cases, please reach out to the 7-8 or interim through SharePoint, and we'll come and do a recording. Until then, we'll see you next time. Thanks.